Hello, and thank you for joining us for today for the second webinar of CHOP's new Clinical Advances in Pediatric Oncology virtual seminar series. My name is Zachary Corrigan, the Senior Director of Provider Engagement at CHOP. We're excited about today's lecture topic, Advanced Pediatric Thyroid Cancer, Is It Time for a Paradigm Shift in Care? And the expert speakers who will be delivering today's lecture. We'll cover three quick housekeeping items before we get started. One, the event is being recorded, and we'll share a copy of the recording with all of the registrants once it is available. Two, we've left ample time at the end for questions. Please use the question button throughout to post questions, but we will be holding question and answer till the very end. Lastly, for those that will be claiming CME, we will be distributing a feedback survey that you can use to claim your CME credit. So with that, allow me to introduce today's faculty. Andy Bauer is an endocrinologist and director of the Pediatric Thyroid Center at Children's Hospital of Philadelphia. Ed Lasik is a pediatric oncologist and leads both the developmental therapeutics program and the very rare malignant tumors program at Children's Hospital of Philadelphia. Lastly, but not least, Goli Mustafa Mo is dual certified pediatric oncologist and endocrinologist with clinical expertise in endocrine late effects after childhood cancer therapy. She is the Richard and Sheila Samford Endowed Chair in Pediatric Oncology at Children's Hospital of Philadelphia. With that, Dr. Bauer, the floor is yours.
Thank you, Zach, and welcome everybody. I'm actually very excited to present this topic because I hope at the end, as Zach already mentioned, that we have time to have a very hopefully energetic discussion, because what I'm going to present is ideas and hopefully some suggestions, recommendations, mostly opinion about how we need to move the evaluation and management of kids with advanced pediatric thyroid cancer forward and trying to change what we've done in the past, including what was recommended in our 2015 guidelines. So I have no relevant disclosures for this topic. There will be some discussion from myself and Ted and Goli as well on off-label use and investigational therapies. The other two disclosures are I am on the second, the chair or co-chair of the second version of the American Thyroid Association guidelines. We're currently working to update the 2000 version and to hopefully fill some gaps based on data that we have over the last 5 years. And the other disclosure is I really don't have an absolute definition. There is no consensus on advanced thyroid cancer as a definition, nor do I have a consensus, or any of us have a consensus on if and when systemic therapy should be considered within this population. I'll first start by saying thank you to my team. Nothing at CHOP or in my clinical and research life happens without a team. We've already mentioned some of the members of the clinical team that you can see in the left corner. Lindsay Cisco is our clinical coordinator who runs the show as far as getting patients in and helping to take care of patients, along with Stephanie, who I don't have a photo of. Amber is our research coordinator, and Julie is a recent research assistant who's joined us. As I'll mention at the end, we had started a translational science program in 2019 in the summer, and Amy Franco runs that program. And then we have a bunch of faculty and friends and colleagues that help us run the program and administratively that you can see down in the corner, Amy, Jamie, and Caitlin, and there's several others as well. So thank you to all of them. So we're going to set the stage with is just some things that everyone should be aware of at this point. So we won't spend a lot of time on this, but that there really is an increased incidence of thyroid cancer, not just in adults, which you can see on the left-hand side of the screen, but as well as in pediatrics. The data from the Midwest, I'm not sure why it didn't show up in this pediatric publication from 2014, but I think it's true across the United States, North America, and also on the global, in our global community. As we know, that most of our patients that present with differentiated thyroid cancer, which is the most common form of thyroid cancer to present within the pediatric age frame, are adolescents. So about 76% of patients are between 15 and 19 years of age, where there's a sex predominance, females to males, of about 4.5 to 1. Many of our patients present with regional metastasis, mostly central neck lymph node metastasis, but also lateral neck metastasis. And at least on the SEER database, which is not complete as far as what's placed in the database, nor complete as far as the percentage of patients that are diagnosed with thyroid cancer probably includes, our estimate is somewhere between 45 and 50% of known patients. But the distant metastasis is reported to be under 10%, which is still 2 to 3 times higher than some adult data, around 8%. But as I'll show you in the next couple slides, there's a group of patients that we have that present with lateral neck metastasis where the risk of pulmonary metastasis is closer to 20%. The question and the comment and many criticisms and many editorials have been written about this in the adult population, but as well as in the pediatric population, that the increased incidence we're seeing may be what some refer to as overdiagnosis. I think that's a dismissive term, and when we talk about a 10-year-old, it's hard to know if something is an overdiagnosis or an early diagnosis. But nonetheless, there is an increased incidence, and I think it's a mix between patients that may have indolent, non-progressive disease if we were to follow them over their lifetime. But I think there's also a group of patients that present with early disease that we happen to pick up serendipitously at times because of head and neck imaging. When we look at the types of cancers that present, papillary thyroid cancer is certainly the one that's seen the greatest incidence, and you can see the rise since 2005, 2006 timeframe. And again, as I mentioned earlier, that it's not just disease that's limited to the thyroid, but there is an increased incidence of patients that are presenting with lymph node metastasis, so regional metastasis. Within the SEER data, there's not a great collection of data on pulmonary metastasis, so I mentioned the 8%, but because of that, there wasn't any graphing and allowing for accurate estimate of the true incidence of pulmonary metastasis within the pediatric population. So in the past, when we think about pediatric patients with thyroid nodules and differentiated thyroid cancer, there's often a relatively standard aggressive approach to evaluation and management. There's a lot of data to suggest that there's an increased risk of malignancy if you just take a 10-year-old with a thyroid nodule compared to a 30-year-old with a thyroid nodule. Somewhere around 5 to 10% for an adult, somewhere around 20 to 25% for an adult, for a pediatric patient. As I mentioned, increased risk of metastasis. And then the data again, which is based on really 2 studies that have been published, one from the Mayo Clinic and one from the UK, showing an increased risk of recurrence over the lifetime of our patients. So up to 30+% of patients over 3 to 4 decades after initial diagnosis. To our benefit and to our patients' benefit, we do see low disease-specific mortality within pediatrics despite relatively high burden of lymph node metastasis and even pulmonary metastasis. So 98% or more of our patients do survive, but within that population, which we won't go into today, there's an increased risk of complications based on age, and there are many opportunities for us to improve how we take care of these patients. So in 2015, we kind of took our first crack at how can we put this into a useful, clinically useful guideline. And so the first version of our American Thyroid Association guidelines were published. The goals were reduce complications, both surgical and medical, to maintain low disease-specific mortality, to achieve remission when possible, and to avoid increased risk of recurrence based on the recommendations within the guidelines. To be fair and to be honest about our initial guidelines, there was very little stratification recommended for surgical care, and most of the medical care was actually looking at how could we reduce the use of radioactive iodine in patients that have a low risk of post-surgical disease. So the next guidelines, there really is a lot of opportunity for us to improve and to expand recommendations once we review the literature and hopefully achieve a consensus along that path, and this talk is part of that. So what patients have advanced disease? I think for all of us who take care of patients, we could say you know it when you see it, but that's not entirely a helpful approach, and it's certainly not going to provide any standard of care or any outcome that's going to actually improve care. I think we actually need to not just say, you know, when you see it, but actually come up with a definition of advanced disease and then decide if and when systemic therapy or additional radioactive iodine therapy would be indicated. For our patients with advanced disease, the majority of these patients will have papillary thyroid cancer, and the majority of these patients will have pulmonary metastasis. And if you look at Kaplan-Meier survival curves, pediatric patients that have distant metastasis, most commonly pulmonary, have decreased survival. And when you look at how do you identify patients with pulmonary metastasis, which can be up to 20%? Knowing the lymph node disease pattern is really important. Patients with N1A disease limited to the central neck, low risk of pulmonary metastasis. Patients with lateral neck disease, up to 20% risk of metastasis. And that's based on the fact that papillary thyroid cancer metastasizes via the lymphatic system, and it's a predictable pattern of drainage from the thyroid to the central to the lateral neck and then distally. Follicular thyroid cancer, which I won't bring up, is mostly hematogenously spread. And thankfully, within pediatrics, there's very few patients that have widely invasive follicular thyroid cancer with distant metastasis. Most of our patients have minimally invasive follicular thyroid cancer. So if we look at our patients with pulmonary metastasis, how well are we doing at treating them? So this is a systematic review that was published in 2010. It was 9 studies, about 112 patients. If we just take out the patients that were less than or equal to 18 years of age, that was 64 patients. And if we look at the response to therapy, partial and non-responders were 42% and almost 11% for non-responders. Follow over these studies was relatively good, up to 29 years. The cumulative dose of radioactive iodine, you can see, is between 59 and 1,050 millicuries. 4 patients had recurrence, and up to 3 patients from this cohort, which out of the 64, we're talking about the pediatric specific patients, almost 5% of patients had death from disease. The problem with this initial study is part of the problem is, one, it's a systematic review, which always has complications because of variance of studies that are included, but also on how they defined responders. So a complete responder in this study was a patient that had a TG less than 10 nanograms per ml and a negative whole body scan. And most of us realize that that's not an adequate definition for a complete responder. And so this raises questions for, even though they list almost 47% complete response, how many actually really had a complete response? In addition, when you look at the radioactive iodine dose that was administered in order to achieve complete response versus partial response, it's kind of mixed. So in some studies, there was an increased amount of radioactive iodine that was used to achieve a complete response. In other studies, there were not. So it's kind of mixed back and forth, and there was some data that wasn't available in several of these studies. I think even more importantly, when you look at the non-responders, despite relatively large doses of radioactive iodine, there was still very little impact on the response rate, which brings, again, the question, when is too much? And should we continue to give radioactive iodine if we're not seeing a response? And that led to some of the recommendations in our 2015 version 1 of our guideline, that there are patients that develop persistent disease that are non-responsive to radioactive iodine. Despite being avid, they still may not respond and just plateau and develop pulmonary mets that don't progress. A follow-on study in 2013, now looking at a different cohort, which arguably is not the same as sporadic disease. This is looking at the survivors of Chernobyl, the pediatric survivors that had radioactive iodine-induced thyroid cancer and somewhat late presentation because of delay in setting up the monitoring system. But it's a nice study because it had a large patient population. So there's 100 patients with pulmonary metastasis compared to 134 patients without pulmonary metastasis. And they're showing, again, a complete response in a relatively high percentage. So 45 out of 100 of patients with M1 disease with pulmonary metastasis were able to achieve a complete response, complete remission. And if you look at the definition, I think this is one that would be more agreeable to the group of providers that are on this webinar. And so this was actually somewhat encouraging. If you look at how much radioactive iodine was administered to these patients, it's a little bit troubling. And so it's a balance between how much should we use to achieve complete remission, how often should we use it, and it brings to question many things that we tried to address again in our first guidelines. So the average number of doses, or the range of doses, was between 2 and 12 per patient. The cumulative dose was between 100 millicuries up to 1,718 millicuries. The median was 456 millicuries. 7% of patients developed lung fibrosis, and there was 1 death associated with their progressive pulmonary metastasis and pulmonary insufficiency. So when the guidelines were published in 2015, what's listed, and you can see the recommendation numbers on this slide, is that all patients with radioactive iodine avid pulmonary disease should receive at least 1 dose of radioactive iodine. And then we suggested subsequent doses based on unresponsive therapy, which I'll show in the next slide. We retreat patients if there's demonstrated progression after initial response, which I think we need to work on how we define progression. And if you have persistent pulmonary disease, we suggest monitoring on TSH suppression if there's no evidence of progression. And systemic therapy is brought up in the 2015 guidelines, but similar to our recommendations on oncogenic evaluation of nodules with indeterminate cytology, there was not enough data to suggest if we should be using this and which patients should be selected and may benefit from systemic therapy. And the only systemic therapy that was listed were the tyrosine kinase inhibitors, sorafenib and lenvatinib, which at the time were the ones that were most adequately studied within the adult population. So the figure from our guidelines in 2015, so a patient with a known distant metastasis after they receive therapeutic radioactive iodine, now they go into monitoring. And we suggested monitoring thyroglobulin or imaging. And the focus on the thyroglobulin monitoring really came out of 2 studies and the realization that one, the top graph that you see here is data from the Chernobyl patients actually collected in Würzburg, Germany by Christoph Reiners and his group. And what happened was they ran out of funding to continue bringing patients to Germany. And so if you look at the red arrow, these were decreasing thyroglobulin levels, and this area of the graph is when they stopped giving radioactive iodine, and despite that, the thyroglobulin continued to decrease. So there was now evidence to suggest that if you give a dose of radioactive iodine, you can continue to see efficacy even after that dose for months afterwards. A follow-on study from Memorial Sloan Kettering published in 2012 again showed similar findings that if after a single dose of radioactive iodine, you can continue to see the thyroglobulin decrease. It may not be a linear decrease. There may be some ups and downs along the way, but you can continue to see a response based on thyroglobulin up to 18, if not even 24 months after the initial dose of radioactive iodine. I think in the next guidelines, clearly, I think the biochemical response is interesting, but not as important as what the anatomic response is. And that's what we'll bring up in the next slides as far as trying to define advanced therapy and trying to come up with a consensus on how do you, if and when you start systemic therapy, and how do you actually measure a response. In the last year, there's been 3 more studies for patients, pediatric patients with pulmonary metastasis. The first one from Al-Zahrani in 2019, they looked at 20 pediatric patients with pulmonary disease. These patients received 1 to 8 doses, up to 682 millicuries. Complete response was achieved in none, 0 out of 20, and there was 1 death within that group. The next study below that is from Sick Kids in Toronto, from Jonathan Wasserman and his group, looking at 19 patients out of 98 patients, pediatric patients with papillary thyroid cancer, 1 to 4 doses, up to 600 millicuries. An excellent response, which was defined within that paper, very similar to the complete response from the Christoph Reiners paper and out of the Chernobyl group, was seen in 16%, and persistent structural disease in almost 70% of patients, 1 death attributable to thyroid cancer. And lastly, out of the Ito Hospital in Japan, 29 patients out of 171 with pulmonary metastasis, up to 600 millicuries again. Complete response, 20%. 3 patients died from disease, with distant metastasis, of course, increasing the risk of death from disease. So out of these more recent papers, just out of the last year, I think there's a couple take-home points. One, there are different patterns to pulmonary metastasis. We do have patients that you only can detect the micronodular, diffuse micronodular disease on the whole body scan. If you did dedicated chest CT, even with high resolution chest CT, you may not see the disease. So it's a very minimal amount. Those patients are actually quite likely to respond to radioactive iodine and to achieve complete remission. But then there's at least 2 other forms, diffuse micronodular disease and even macronodular disease. So there's different types of pulmonary disease within pediatric papillary thyroid cancer and in adults as well. Complete response, excellent response is uncommon. And within these three groups, this is, again, not a prospective study, not a huge number of patients, but death from disease is not zero. So out of these three studies, and I showed you a couple other studies, maybe as high as 5%, and that's not necessarily following patients out over their lifetime. So this is even within the pediatric time frame. So when we go back to our guidelines again, when we discussed radioactive iodine, we didn't really, but we tried to, but we didn't completely answer how much radioactive iodine is too much. We did address that there's toxicities in radioactive iodine, early, intermediate, and long term. Pulmonary fibrosis is something all of us are trying to avoid. So we recommended empiric dosing if you don't have pulmonary metastasis, but dosimetry is for younger patients and especially for patients with pulmonary metastasis, and especially for patients that will receive more than one treatment dose. Gonatotoxicity does increase, at least at the data at the time. So we recommended sperm banking for patients that were receiving more than 400 millicuries if they were post-pubertal. The long-term complications, which was almost 8% in that study from Chernobyl, we don't know if it's the disease causing the pulmonary metastasis, or if it's the treatment of the disease, or if it's both. But it is something that we do try to avoid, and that's why spacing out treatments is one way of trying to do that, as long as you follow patients with anatomic imaging to ensure that, to one, assess the response to treatment, and two, to ensure there's no progression. And then the increased rate of second malignancies. There are data. They're somewhat difficult to interpret, but the consensus from the guideline committee in 2015 was an increase. You start to see an increase after 200 to 300 millicuries per patient. So how do we define refractory disease? Well, in adults, it's no radioactive iodine on a whole body scan with anatomic disease, anatomic progression despite radioactive iodine, or anatomic progression despite cumulative doses of 600 or more millicuries. There was a consensus statement that was published in 2019. Mike Tuttle was the first author, but there still continues to be a question of, if it's working, why would you not continue to give additional doses, working by the definition of decreased anatomic burden of disease. And so the other study to look at is somewhat of an editorial study by Giovanelli and Doug Van Ostrand, and they list about 13 different things to consider once you're thinking about a second dose of radioactive iodine, or during your consideration for a second dose. So systemic therapy in pediatrics, I was introduced to this early, I guess, because Steve Wagesbeck published a single case report on sorafenib in 2006. But at least in my own clinical practice, it was one of our patients with diffuse sclerosing variant papillary thyroid cancer, presented with progressive pulmonary disease despite repeated radioactive iodine in a very short period of time, within 2 years. Our patient had avid disease, but despite the avidity and despite an increase in dose on the second treatment dose, she continued to have progression. Since that time, I think all of us are starting to see other patients now where we wonder if the standard approach of surgery and radioactive iodine is the right approach in differentiated thyroid cancer, and also for patients with medullary thyroid cancer, now that we have available systemic therapies, if and when we should be using those as well. So we have patients, and there's been a number of case reports that present with hypoxia. So this is a patient that we had that had hypoxia room air sats in the 80s, low 80s, and before receiving radioactive iodine. And so treatment of systemic therapy to try to reduce the burden, to relieve the hypoxia, and then subsequently giving radioactive iodine was pursued. We have also patients that present. This is a patient at the top with medullary thyroid cancer. This is an 18-year-old that presented with tracheal compression and encasement of the great vessels. And despite, consultation with a high-risk adult head and neck and thoracic surgical team, they felt that the morbidity of disease was too great. This patient had medullary thyroid cancer and subsequently went on systemic therapy, which I'll show you. Or we have another patient. This is a patient from one of our collaborators in our paper that was published this year that had a 9-year-old that presented with tracheal invasion, actually had a tracheal resection. And the question was, would systemic therapy have helped reduce that or even potentially avoided that? So in our paper, we bring up that maybe for patients with morbidly, locally, regionally invasive disease, systemic therapy could be considered even before surgery. For patients with medullary thyroid cancer, most of our patients have MEN2B. We don't see that much sporadic disease in pediatrics. 75% have a hereditary form, which the most invasive forms are the MEN2Bs with 918 germline mutations, or the 634s in the MEN2A patients. And we know with this excellent study that came out in 2019, looking at over 300 MEN2B patients, that survival decreases once there's distant metastasis. So here's a 12-year-old patient of ours that has liver metastasis with MEN2B, and then a teenager with MEN2B who developed pulmonary metastasis. So what do we do when radioactive iodine doesn't work? Well, fortunately, thyroid cancer has a relatively quiet, relatively simple pattern for driver mutation as the cause of conversion from a normal thyroid cell into to differentiate into a papillary or follicular thyroid cancer, or even for progression from a normal C cell to medullary thyroid cancer. And many of these oncogenes, whether they're mutations or fusions, are actually targetable. So I think we're in a good position where this type of therapy has shown efficacy in adults and should be considered now in pediatrics. Some of these genes do correlate with invasive behavior. So there are certain somatic mutations, RAS, DICER, PTEN, PAX8, that are associated with less invasive disease, and there are certain driver mutations that are associated with more invasive disease. So BRAF, the RET, NTRK, ALK, and BRAF fusions are also associated with more invasive disease, and this is just an ultrasound of a patient with left lobe involvement of diffuse sclerosing variant PTC in a lateral neck lymph node. But knowing the driver mutation does not define invasion, it just predicts invasion. So we do have patients with BRAF that don't have central neck disease. We do have patients with fusions that don't have lateral or pulmonary metastasis, but it does raise, it should raise awareness of the potential for progression and the potential for response to therapy. And once we know that information, then we go into our routine. So laboratory assessment, our globin, calcitonin for medullary thyroid cancer, CEA as well, and radiologic assessment using oftentimes non-nuclear medicine imaging, ultrasound and CT, and then nuclear imaging if and when we're thinking about therapy, or if and when we have a discrepancy between the biochemical markers and the non-nuclear medicine imaging. So how do we develop a consensus on what is advanced thyroid cancer? Well, locally, we can define it by surgically morbid disease, so a patient that presents with pre-surgical recurrent laryngeal nerve paralysis or paresis. I think gone are the days when we want our surgeons to purposely resect or transect a recurrent laryngeal nerve in an effort to achieve surgical remission. It's much better to leave disease and then to see if radioactive iodine will destroy it, and then if we know the oncogene, we can use subsequent therapy if and when that's indicated. The aerodigestive tract, which is really uncommon in pediatrics, but I presented that one case. As far as distant metastasis, most frequently pulmonary, but we do know cases where pediatric patients have developed brain and bone metastasis. Morbid presentation, again, defined by hypoxia if it's pulmonary metastasis, or it could be a pathologic fracture if it was a bone metastasis. Progressive anatomic differentiated thyroid cancer despite avidity, which I showed you that one patient. Progressive non-radioactive iodine avid differentiated thyroid cancer, and then progressive MTC. And you can see out of those four, I use the word progressive in front of all of those because I think showing anatomic progression by serial imaging is quite important to help select patients for systemic therapy. So just as a matter of how we've treated patients at CHOP, in the last 10 years, we've had about 31 patients with pulmonary metastasis with differentiated thyroid cancer. We're still actively following in the mid-20s. There's only 3 of our patients that are on systemic therapy. The one that I showed you is on lenvatinib, but we have another patient on lenvatinib, and Goli just started a patient on larotrectinib who presented with pre-RAI hypoxia due to high burden pulmonary metastasis, as you can see in the images here. And we have 2 more patients that we're now considering if they're showing anatomic progression, if we're ready to start systemic therapy. So in the paper that we published in 2020, I think most of the patients will continue the same approach. This is fewer patients will need or benefit from systemic therapy, but there certainly are patients that will benefit from systemic therapy. And we just came up with a list of if and when and who those patients may be. And for patients with differentiated thyroid cancer, some of these agents may be pre-radioactive iodine or in addition to radioactive iodine. And some of our medullary patients, some of these patients may actually be instead of surgery. So if the patients are responding to systemic therapy and there's no chance of achieving remission, there are some patients with medullary advanced metastatic medullary thyroid cancer where systemic therapy may be used instead of surgery. So you have to look at the response. What systemic agent should be considered first line? You'd be surprised. The patients know these things. So we know that tyrosine kinase inhibitors have FDA approval. They were used prior to the discovery of these oncogene-specific targeted therapies. And we have patients that ask us, well, why would you start with tyrosine kinase inhibitors when you know there's an oncogene-specific targeted therapy that's more effective? If you talk to some of the adult oncologists, I've been working with Marcia Bros for the last 3 years, oftentimes still they start with tyrosine kinase inhibitors, and then they resort to oncogene-specific therapy. One, if they know what the oncogene is, so you have to know what the driver mutation is. And two, if the patient fails or develops adverse or side effects from a tyrosine kinase inhibitor. But within pediatrics, I think we need to have a discussion. What's the best approach for our patients? How do we define response to therapy? As I mentioned before, I think anatomically is the most important. Once you start systemic therapy, oftentimes the biochemical markers actually increase. TG increases, calcitonin increases. So you can't just use biochemical markers. You have to have something you can measure on imaging. Even if it doesn't meet RECIST criteria, it still has to be measurable on serial imaging. And one of the biggest questions is, once you start it, when can you stop it? And that's a question that I think is going to take some time to answer. Most people are afraid to stop it. And so this is, when we're talking about 10, 12, 15-year-olds, this is a big decision to be making. In addition, as I already mentioned, we're not doing a great job of getting rid of patients' pulmonary metastasis. Many of them don't progress, but it's still a huge burden for our patients to know they have persistent stable disease. And the question is, can we do something to help decrease that percentage? So can you use some of these agents in a pre-radioactive iodine manner to help increase the efficacy of radioactive iodine and decrease the likelihood of persistent stable pulmonary disease? And this information came from at least several studies, recent studies. Or initial study was published in adults. Again, these are in JCEM in 2018, using MEK and BRAF inhibitors, which showed redifferentiation of the thyroid cancer that was not avid to an avid state where radioactive iodine could subsequently be used. And then a recent case report, not just looking at MEK and BRAF, but now looking at NTRK fusion inhibitor lorlatinib, and similarly showing the ability to redifferentiate to increase sodium iodine symporter expression and potentially allow for additional radioactive iodine. I'll tell you, there's also some data in pediatrics that will soon be published as well on that topic. So here's a patient of ours that had diffuse sclerosing variant PTC, had pulmonary metastasis. This patient has an NTRK fusion, has received 2 doses of radioactive iodine. The cumulative dose is now 220 millicuries. The last dose was about 2 years ago, has some macro and micronodular disease. And we've been following this patient for 2 years, but they have measurable disease. And the question is, which we've been going back and forth on, I don't have the answer for you, is should we initiate systemic therapy or should we wait for progression? And especially if we have a targetable mutation like an NTRK fusion. So I think it's a very exciting time. I'm going to end with just a couple slides. I mean, it's been a long time since we've had a new agent within our armamentarium to be able to treat patients outside of just surgery and radioactive iodine. I mean, 1948, this was when radioactive iodine was first used, and it is a wonderfully targetable, effective treatment for the majority of our patients with distant metastasis, but not for all. In the 21st century, we now have improved understanding of the oncogenic landscape, not just for diagnosis, I think, which we didn't go into today. I think we can use it for surgical stratification. I also think it provides really a wonderful opportunity to think about how and who would benefit from medical therapy, mostly talking about systemic therapy. So here's our patient that I presented earlier. She's been on lenvatinib for 3.5 years. You can see she's not cured, but she has a marked reduction in her pulmonary metastasis. Here's a patient that I presented with the medullary thyroid cancer just after 3 months of BLU-667, which is pralsetinib, of a RET inhibitor, has had marked reduction in her the size of her tumor, and she's had subsequently response after these images as well. So as I said, I've been working with Marcia Bro since 2017, and now we're advancing and expanding our program within CHOP so that our patients can be more directly cared for by Ted, Frank, and Goalie, and myself as well. Patients with medullary thyroid cancer, so this patient of ours is on Vendetinib and doing fine, and this patient was started on Pralsetinib. So we've had a very nice program at CHOP. I think we've been very, very personally rewarding. I have a wonderful team, as I showed at the beginning, but creating and now organizing a advanced pediatric thyroid cancer therapeutics clinic really, I think, is another important step for all of us to be considering at our own institutes. In 2019, as I mentioned, we started a translational program. We have mouse models now. We have primary thyroid cancer cell lines, which we've derived from patients, NTRK fusions, RET fusions, and hope to start a BRAF line as well. So there is a lot of opportunity for us to work together to expand and improve our care for these patients. As I said, we're working on the ATA second version of the guidelines, and we've since now, in the last year, finally have approval for a North American consortium that is meant to be a collaborative effort. We'll have a clinical registry, a biorepository where samples can be sent, and we can do molecular landscape analysis, and also another opportunity to have multi-center studies. The COG is now actively working. Ted, Goalie, and Raj, Venkatramani, and several other people to actually create a prospective protocol within pediatrics for radioactive iodine therapy to try to improve care. There's been a number of studies, this is just 4 listed here, where systemic therapy, at least in case reports, has been published within pediatrics, and several of our colleagues have presented another talk, through the ATA, a different talk on advanced thyroid cancer therapeutics and how and when to institute care. So our CAT-C, as you can see, the executive board is our group at CHOP, Stephen Wagespeck from MD Anderson, Jonathan Wasserman from Sick Kids, Catherine Denauer and Emily Christensen-Legay from Yale, and Ari Wassner from Boston. But we have 19 other institutes now that we have funding through our Frontier program, and our contract has been approved to expand so we can all start working together to help define what is advanced disease and if and when systemic therapy should be instituted, and how to best manage patients on systemic therapy. So with that, I'll end and let Ted bring in his slides and tell you a little bit about the therapeutics program at CHOP. Thank you.
Thank you, Andy. So I'm Ted Leitch. I'm a pediatric oncologist and excited to talk to you about my perspective on advanced pediatric thyroid cancer, particularly from a developmental therapeutics perspective or a new agents perspective. I lead the developmental therapeutics program here. Here are my disclosures, including that I have consulted for a number of pharmaceutical companies on pediatric clinical trial design, that I will discuss off-label use in investigational therapies, and that while I chair the Children's Oncology Group Rare Tumors Committee, which does cover thyroid cancer, the following is my personal opinion and not a COG opinion. So Andy, Dr. Bowers showed this slide highlighting the genetic alterations that occur in pediatric thyroid cancer. I look at this as an oncologist. It's remarkable how many of these tumors have targetable mutations. In general, in pediatric oncology, probably a quarter to half of tumors may have targetable mutations, but many of those, the level of evidence for targetability is pretty low. That's quite contrasted by pediatric thyroid cancer, where over half of cases likely have a highly targetable kinase activating alteration. And in fact, the mutations that Dr. Bowers showed that are associated with more risk of invasive disease are all targetable mutations: BRAF, RET, NTRK, ALK, and BRAF fusions. And so it really is an opportunity to think about how do we use these new agents that have been developed and studied, and where is the appropriate use for them in children who have advanced thyroid cancer. So Dr. Bauer mentioned the use of tyrosine kinase inhibitors, and really, when I think about these, there's two classes. There are broad multi-tyrosine kinase inhibitors, which are called targeted therapy, but are actually not very targeted, and they inhibit quite a large number of different receptor tyrosine kinases. And these were the first agents that were studied for thyroid cancer and are approved for both differentiated and medullary thyroid cancer in adult patients, and really work by generally blocking the pro-growth signals that occur both within the tumor cells themselves as well as within the vascular endothelial cells, resulting in an anti-angiogenic effect. And so for differentiated thyroid cancer, lenvatinib and sorafenib are both approved, and for medullary cancer, vendetinib and cabozantinib, which are both RET inhibitors, but again, that inhibit many other genes as kinases as well, are approved. And both of these classes of agents were studied in traditional randomized controlled trials against placebo, and both classes of agents have shown improvement in progression-free survival against placebo in adult patients with thyroid cancer. So on the left, you can see lenvatinib in patients with differentiated thyroid cancer, and on the right, you can see vendetinib in patients with medullary thyroid cancer. And again, both show improvements in progression-free survival versus placebo. Neither of these classes of agents have specific FDA approval for children, but pediatric phase 1 trials have been completed for all of them, and so there is pediatric dosing available. In my opinion, little reason to think there would be differential responses in children versus adults. But as Dr. Bauer mentioned, I think one of the really exciting things that has happened over the last 5 to 10 years with broad use of next generation sequencing, the identification of specific molecular alterations driving individual tumors, and then over the last few years, FDA approval of several agents that target these specific genetic alterations, which may have advantages over these broad tyrosine kinase inhibitors, both in terms of efficacy and in terms of toxicity, if there's less off-target side effects. So the most specific of these for thyroid cancer is selpercatinib, which is a highly selective RET inhibitor that is now approved for both children and adults, patients over 12 years of age with radioactive iodine refractory or inappropriate thyroid cancer. And what you can see here is the response rate to this therapy. So these are waterfall plots where each patient is a column, and decreasing tumor size is shown below the 0 axis. And in patients with RET mutant medullary thyroid cancer on the left, you can see that there was a 69% overall response rate, even among patients who had previously been treated with either vendetinib, cabozantinib, or both, including 3 patients who achieved complete response with selpercatinib despite failure of both vendetinib and cabozantinib. And on the right, you can see the response rate in patients with RET fusion thyroid cancer, primarily papillary thyroid cancer shown in blue, but other forms of thyroid cancer as well were also included in this study if they had a RET fusion. And again, there was a 79% overall response rate, including a couple of complete responses shown on the right. So very active, although they were not conducted in randomized trials against a placebo, so we don't have the same data yet on progression-free survival versus placebo. NTRK fusions are also common in thyroid cancer, and there are now a couple of NTRK inhibitors that have been approved for children. Larotrectinib is a highly selective NTRK inhibitor or TRK inhibitor that's FDA approved for children and adults with refractory thyroid cancer. With refractory NTRK fusion positive cancers, regardless of histology. So this does include thyroid cancer, but is not specific to thyroid cancer. And here you can see again another waterfall plot showing the different histologies of patients that were included on the studies of larotrectinib, both in children and adults. Across all the histologies, the overall response rate was 78%, including 92% in children. There were 59 children included as of this most recent update in the study, and 36% of those children had complete responses to larotrectinib therapy. In the middle here, shown in green, are the patients with thyroid cancer. So there were 26 patients with thyroid cancer included in this analysis. And again, there was a high level of activity in these patients, including in patients who had CNS metastases, shown by the crosses, and including 5 patients who had complete response, shown on the right. Entrectinib is the other FDA-approved TRK inhibitor. It is a broader kinase inhibitor that inhibits TRK, ALK, and ROS1, and is approved for patients over 12 years of age with refractory NTRK fusion cancers. Again, there was a high level of activity seen in this waterfall plot with an overall 57% objective response rate in patients. These are adult patients with TRK fusion cancers of a variety of different histologies. The patients with thyroid cancer are shown in yellow, and so there were a limited number of these patients, but again, you see activity in these patients, suggesting that either larotrectinib or entrectinib may be used for patients with advanced thyroid cancer. And there are a number of other agents that, while not specifically FDA approved, are able to be used off-label to target mutations and have shown high level of activity against some tumor types bearing the mutations that are common in pediatric thyroid cancer. So these include BRAF V600E inhibitors, and so dabrafenib and trametinib is actually FDA approved for adult patients with metastatic anaplastic thyroid cancer. Well, that's very rare in pediatric patients, but the same BRAF V600E mutations occur in papillary thyroid cancer, and these agents may be considered in that case. So on the left, you can see work actually led by our collaborator at Penn, Dr. Bros, showing the efficacy of vemurafenib, a BRAF V600E inhibitor, in patients with papillary thyroid cancer with V600E mutation. And there was a 39% overall response rate to this agent. And on the right, you can see the data that led to FDA approval of dabrafenib and trametinib, demonstrating a 69% overall response rate among adult patients with BRAF V600E mutated anaplastic thyroid cancer. Again, while dabrafenib, trametinib are not indicated in pediatric patients, pediatric phase 1-2 trials have been completed, and these have been generally well-tolerated agents with a high level of activity in several ongoing studies among patients with V600E mutated gliomas. And there was at least one patient with papillary thyroid cancer with a V600E mutation included on the pediatric phase 1 study of dabrafenib, who, as of the last report, had ongoing treatment without progression for more than 2 years. ALK fusions are less common, but do also occur in papillary thyroid cancer, and several studies have now shown robust activity of ALK inhibitors against pediatric ALK fusion positive cancer. So both crizotinib, a first-generation ALK inhibitor, and ceritinib, a second-generation inhibitor, have been studied in patients with inflammatory myofibroblastic tumor characterized by ALK fusions, and anaplastic large cell lymphoma, also characterized by ALK fusions. And across both of these agents, the overall response rate, the objective response rate, has been 70 to 90%. So very high level of activity, suggesting, again, that these agents may be of benefit for patients with ALK fusion positive tumors. So moving on from agents that can be used off-label to current clinical trials, this is a list of the trials that we have open here at CHOP for patients with different kinase activating alterations that would include patients with thyroid cancer. These include selpercatinib, the pediatric study of the agent that's approved for patients 12 years and older, is being studied in children here with relapsed and refractory solid tumors with either RET mutation or RET fusion. We have several trials of NTRK inhibitors, both the first-generation inhibitors, larotrectinib and entrectinib, as well as second-generation inhibitors that can block some resistance mutations, including selatrectinib and repotrectinib. And then there are also studies of the BRAF V600E inhibitors as well as ALK inhibitors. I'd highlight that we have an ongoing phase 2 trial of larotrectinib through the Children's Oncology Group. Is actually studying patients with newly diagnosed TRK fusion positive cancers prior to other systemic or radiotherapy to evaluate the response rate for patients with any histology of TRK fusion positive cancers. And Dr. Bauer highlighted this, but I would just say that I think it is really critical to have this strong collaboration between endocrinology, oncology, and developmental therapeutics to have a successful advanced thyroid cancer therapeutics clinic, because we really need the expertise of each of these groups of patients, the endocrinologists for their disease-related expertise related to thyroid cancer, and then oncologists and developmental therapeutics team, because of the way these kinase inhibitors have been developed primarily through oncology. And our approach here is that we have a multidisciplinary clinic and case conference for patients with advanced thyroid cancer who may be candidates for systemic therapy to talk about the options, and as Dr. Bauer mentioned, talk about the risks and benefits of multi-tyrosine kinase inhibitors versus these new oncogene-specific targeted therapies. As Dr. Bauer mentioned, we couldn't function without the rest of our team, and so it is really the nurse practitioners, nurses, intake coordinators, research coordinators, the entire team that make this team function. And our patients can access this through either endocrinology or oncology, and we have a close collaboration between the two groups to make sure that the patients get the best care. Dr. Bauer briefly mentioned this, but I would just highlight that we are now planning a study to evaluate whether oncogene-specific targeted therapy can increase radioactive iodine uptake in children with advanced thyroid cancer. Dr. Bauer highlighted that there were case reports and case series of patients who had either a RET inhibitor, selumetinib, or now larotrectinib with TRK fusion positive tumors who had re-expression of the sodium iodine symporter and reactivation of RAI uptake in the setting of targeted therapy in adult patients, and we would like to explore this in children. And really the goal is to determine whether we can improve the anatomic response in patients with lung metastases, and then hopefully potentially reduce the need for multiple RAI doses and the complications that Dr. Bauer discussed. And I'd also highlight that I think the preclinical bench-to-bedside translation is very critical, and we're super excited to have Dr. Amy Franco here to direct the Pediatric Thyroid Cancer Translational Research Laboratory to develop preclinical patient-derived and murine models of thyroid cancer and better understand the impact of these systemic therapies and how best to use and sequence them in the context of radioiodine. I'd like to thank all of you for your attention, and I think we'd be happy to take any questions.
Thank you so much. So just a reminder to post your questions. You should see a question button. If you type your questions in, we have a team ready to start asking the questions aloud and address them. Well, while we're getting started, I'll post one question. Obviously, I think one of the strengths for our team has been the collaboration between our endocrinology colleagues and our hematology oncology colleagues. Do you have any kind of pearls of wisdom for any of our participants that might be looking to sort of establish that same level of collaboration within their own centers?
Goli, do you want to address that as our...
I'm happy to address that. I mean, I think the key here is really collaboration. I think thyroid cancer, though it is a malignancy, traditionally has been under the umbrella of pediatric endocrinologists. On the adult side, it's predominantly also been adult endocrinologists. So I think what is more important is, especially as we shift away from the old paradigms of surgery, radioactive iodine, and kind of venturing into the more advanced systemic therapy and better approaches in a way to really reduce morbidity in the long run for these patients, I think the collaboration is absolutely essential. And I think it's just more making sure that there's that comfort zone in terms of making this as a group effort, because the oncologists clearly need the endocrinologist to kind of manage the endocrine associated parts of this malignancy in addition to, addressing. So I think it's kind of opening that partnership and the dialogue, and not necessarily feeling that one has to own this cancer versus the other. So I think that partnership and multidisciplinary, having clinics where both disciplines are there, where a patient comes to basically one clinic and actually sees the different disciplines, and it also facilitates communication and dialogue. So I think that to me is thankfully the new way of how we are practicing medicine, and certainly it's a way to make sure that this malignancy is appropriately, targeted. And Andy, if you have any additional comments and your thoughts.
I couldn't agree more. I mean, it's been unbelievably satisfying. Goalie and I have been building this together since 2009, and every year we've been adding and finding one or two more people that are passionate about taking care of patients with pediatric thyroid disease and trying to figure out how we can do a better job. So it's been, and as we've gone on, now that we have systemic therapy, I know what I know and I know what I don't know. And I'm not someone who's going to prescribe chemotherapy without someone like Goalie and Ted and Frank Bayless. So it really does take a team to know where your strengths are and to take advantage of your strengths. And it's been really, really rewarding, I think, personally, professionally, and also really beneficial for our patients.
Yeah, I think also add on that is, I think thyroid cancer is also a kind of cancer, a type of cancer where you really need to sometimes shift as an oncologist your approach to treatment of cancer, where every small lesion that you identify that is also representative of disease does not have to be absolutely eradicated. So it is a tumor model that in some ways you can actually harm the patient by over-treatment. And I think that's where it's really helpful to have the perspective of the endocrinologists who have experience with this disease, in addition to the oncologists who bring their expertise. So in the end, really that expertise comes together and truly benefits the patient in that multidisciplinary fashion. And Ted, I'll pass it on to you because I know I cut you off inadvertently.
No, that's okay. No, I was just going to agree. I agree that it has to be highly collaborative, and the endocrinologists who have managed thyroid cancer long before oncologists got involved have a lot of disease-specific expertise, and I think it really is that collaboration between us oncologists who understand these targeted therapies and endocrinologists who understand the disease best, working together can provide the best care.
All right, great. It looks like we have some questions coming in. The first question says, can oncogene testing be done on the original pathology, or are we doing it with blood testing?
The somatic analysis is on the original tumor. So the technology now, you can do the somatic oncogene testing. There's commercially available panels. We have one that's specific at CHOP that is available for other institutes to use, and there's a couple of other companies, obviously, that are involved in this that have even been ahead of us. So it's off of the tumor sample. Paraffin embedded can be used. Fresh frozen is ideal. Many of them actually can also be done off of FNA. So it depends on if and when, but it's a somatic analysis, and then depending on what the allelic frequency is in the family history, there may be or the identified gene, there may be subsequent germline testing that would be indicated.
And I would say that there are a lot of efforts in oncology to develop circulating tumor DNA tests that could use blood to identify somatic alteration. Many of the kinase fusions are the most difficult to identify through that type of testing because there are a variety of different breakpoints. And so I still prefer to use somatic tumor testing on the tumor as the key to identify potential alterations.
Okay, great. So we do have a few other questions. I know we may be running out of time, so not sure how much further we'll go, but one other question is, are there upcoming guidelines expected to include recommendations such as molecular testing for all or some pediatric patients?
Well, we hope, a personal opinion, I have to get the ATA guideline committee to agree to reach a consensus that the second version of the American Thyroid Association guidelines would be provide more information and guidance on if and when to do molecular testing and what to do with the results. If not, I think we could easily come up with another paper and maybe a consensus among attendees, even across different institutes, even without outside of that, or we could at least propose an idea and then move forward from there.
But I think that this is actually a perfect example of how the joint efforts between, endocrine and oncology, bringing the oncology model to a tumor that traditionally has been treated with a different specialist is this technology and kind of the automatic approach. I think any child who is diagnosed with a solid tumor malignancy will automatically have their tumor sequenced. So I think at any institution, particularly if the child is treated with the children's oncology group, and I think thyroid cancer should be easily approached and appropriately considered as that. And so even if the port of entry for that child's diagnosis is either through a community hospital, either a surgeon who is performing the operation or a pediatric endocrinologist, I think that that's where having established guidelines will help, where pathology automatically will consider this solid tumor diagnosis and send the appropriate, genetic testing that happens on tumors with, other solid tumors as well.
All right. Zach, what do you think? Do we have another question?
I was going to say, yeah, so we can, since we are recording the lecture, I think let's address all of the questions if the faculty have time to stay on to answer them, knowing some folks may have to drop off. But since we are recording, let's get all the questions into the recording.
Perfect. Okay, so I'm going to go back to the beginning. Next question is, can we use targeted therapy in a 5-year-old with MTC with lung metastasis?
I'll let Ted answer. I have an opinion.
So I would say that would be best done on a clinical trial, and that there are a number of clinical trials of RET inhibitors, particularly a Pattem that is ongoing, that would enroll such a patient. And so that would be my suggestion. But Dr. Bauer?
Yeah, no, I'm glad. I mean, that's why it takes a team. And I think looking at it from the endocrine side, it depends on the amount of metastasis and the progression of metastasis. So oftentimes, once we identify it, we may get serial imaging every 6 months. So not just looking at calciton and CEA, but looking at anatomic progression, and that will help, working with Ted and Goli and Frank, help us decide if and when systemic therapy would be net beneficial. And that's one of the advantages and one of the burdens of thyroid cancer is it's a relatively slowly growing tumor. So it's typically not as acute as many other cancers that the oncologists are used to working with. And some time, we do have time to help determine what the rate of progression is before we decide on that type of approach, which is very troubling to families. So you have to be very empathetic about it. But in a 5-year-old, I think, as Ted already mentioned, a trial would be indicated. You just have to figure out where and when would be the appropriate time to initiate therapy.
All right, great. The next question says, can we see patients with out-of-state Medicaid? I guess I can answer that. Absolutely. Absolutely reach out to the Thyroid Center at chap.edu or our phone number or Oncology Amy Buttle, and we can definitely help you get that through. We have insurance specialists. We actually got a California Medicaid patient recently approved to come out. So I think we have all the correct people in place to get out-of-state Medicaids approved.
And an important follow-up to that is in continuing working with the local treatment team, because as everyone knows, as I already mentioned, once you start therapy, if the person is going to benefit from therapy, it will take more than one visit. And just because of, let alone COVID, but just because of resources for families, it will take a collaborative approach between CHOP and other centers that refer to help take care of these patients. Is that fair, Ted? The only limitation will be on study and what would be required under the study protocol if they're on study.
Correct. Yes. So for patients who are on study, because of study requirements, they may have to come more frequently. But absolutely, we would look to work with the local oncologists and endocrinologists to take care of these patients.
Okay, very good. So on to the next question. Can we add patients to this ongoing study with rare mutations like ALK fusion from other countries outside of the US?
I'll let Amber try to answer that. For our Child and Adolescent Thyroid Consortium, right now it's North America, although we have Jonathan who's at Kids Toronto, but we have at least 2 other thyroid centers, international thyroid centers that are interested. And so we are going to work to allow this, to expand this to the international community. So if you can contact us, and Amber might go into a little bit more details, we can start working towards that. It'll probably be in the next 6 to 12 months as we move forward.
Yeah, I agree. So you can contact us for the consortium efforts. I don't know if Ted or anyone wants to speak to just if we have open oncology trials, how international patients might be able to come to the US to enroll in a trial. I know that it happens. I just am not well versed in that process. So I can let you guys take that one.
Sure. So Amy, do you want to discuss?
Sure. So we do have a dedicated division here at CHOP called CHOP Global Medicine. So for the international patients, as far as referrals go, they would go through that intake team. I'm the access supervisor for oncology, and we handle the domestic patients. So whether someone reaches out to me domestically or internationally, I can get you in touch with the right person to start the process of, being approved for a visit.
All right, perfect. So I'll take the next question here. It looks like it might be the last one. What would you recommend for patients diagnosed several years ago with no identified oncogene regarding targeted therapies if needed in the future?
We might have 2 or 3 responses. What we've done is the tyrosine kinase inhibitors are not oncogene specific. So if there's evidence of anatomic progression, that can be considered. There's other therapies that might be considered depending on the location of the lesion. And I think it's always worthwhile to consider reassessing the tumor. So whether it's a fresh sample, if it's something that's achievable by FNA, or if it's just the primary sample that could be rerun on a newer, updated next generation sequencing panel, I think both those things would be potential to help to figure out if therapy and what therapy would be best for the patient. Heather Goley, any other thoughts on that?
Yeah, I think I can definitely at least attest, even over the past 10 years as someone who finished fellowship and now been practicing pediatric oncology, there's been a really change in paradigm in terms of how we even approach relapsed malignancies. And I think that majority of time we actually advocate for new tissue to reevaluate, mainly more because technology changes in the interim, and a lot of the newer generation evaluations of tumor are far more sensitive to pick up targeted mutations that may not have necessarily been identified 5 years or longer ago. And then more importantly, additional mutations or abnormalities in the tumor that are really the result of the progression that truly have to be the target of the therapy may not have been identified in the first tumor identification. So I think majority of us in the field of pediatric oncology typically like to rebiopsy if the tumor has progressed several years after it's been in remission. That I'll let you.
I don't have much more to add. I agree with both you and Andy. I think repeat molecular testing will be critical unless it's been performed in the very recent past, because we have had a number of technological advances and increased understanding of what needs to be evaluated. And as Andy mentioned, there are non-oncogene specific tyrosine kinase inhibitors that can be used even for patients when there is no identifiable driver or the driver is not targetable. So I think both of those would be reasonable options to consider.
And our interventional radiology colleagues in pediatric field have really expanded their biopsy skills and now have incorporated ways where the tissue that's obtained actually is sufficient for us to gain the information that we need. So I think that really has reduced the morbidity in terms of the goal and the approach of trying to rebiopsy. So I think that in and of itself is also another reason why a lot of these approaches actually can be done fairly safely in practice as well.
Well, wonderful. Appreciate we've got to the end of the Q&A. So thank everyone so much for your time today, for the attendees. We welcome the collaboration and hope that we're able to continue collaborating moving forward. And thanks so much today for our faculty and for the rest of the team members that helped with the question and answer period.
Thanks to everyone.
Yes, thank you all.